Hey everyone, and welcome to today's Explainer. We are jumping straight into a seriously high-yield clinical review of iron and vitamin K therapies. We've tailored this explainer specifically to build a rock-solid mental framework for those of you prepping for medical board exams or just looking to really sharpen up your clinical pharmacology skills. We're going to break down the exact mechanisms, the critical indications, and those absolute contraindications you absolutely need to know to crush your exams, and most importantly, keep your future patients safe. Let's get started.
Okay, let's dive into this. Here is our rapid-fire agenda for today. We'll kick things off with core pharmacology definitions, move right into mechanisms of action, do a deep dive clinical review of iron and vitamin K therapies, and then wrap the whole thing up with a quick exam revision summary.
Section 1. Core pharmacology definitions. Before we master the drugs, we need to anchor ourselves. First up is mechanism of action, or MOA. By definition, this is the very specific biochemical interaction through which a drug substance produces its pharmacological effect, right? So it's not just about knowing what a drug does in a broad sense. It's about the precise biochemical mechanism making it happen. A perfect example is understanding exactly how vitamin K acts as a crucial cofactor for the late-stage synthesis of coagulation proteins right there in the liver. Next, we have contraindication. Basically, think of this as a specific situation where a drug, procedure, or surgery absolutely should not be used because it could seriously harm the patient. For example, administering iron sorbitol citrate intravenously is strictly contraindicated. Why? Because it causes this massive rapid transferrin saturation. Recognizing these isn't just a hurdle for passing a test. These are literal life-saving safety boundaries you cannot cross in practice. And rounding out our definitions, side effect or adverse effect. This is any unwanted, undesirable effect produced by a drug. Some high-yield examples you'll definitely see include acute iron poisoning, especially in pediatric patients, or paradoxical hypercoagulation and dermal vascular necrosis. You might actually know that one better as purple toe syndrome, which can pop up during early warfarin therapy. Spotting these adverse outcomes is an incredibly high-yield exam skill for sure. Section 2. Mechanisms of action explained. Let's look under the hood. Now, what's really interesting about this mechanism is how the liver produces clotting factors. The liver handles the production, sure, but 4 specific factors absolutely require vitamin K to actually become active. It's like a metabolic key. You have this continuous vitamin K cycle transitioning from its active form to its inactive epoxide form and back again. And inhibitors, like Warfarin, they step in and directly disrupt that exact regenerative cycle. So let's break that down into 3 punchy, highly testable steps. Step 1, vitamin K steps up as a crucial cofactor. Step 2, it facilitates the gamma carboxylation of glutamate residues. And step 3, this late-stage synthesis by the liver is what specifically activates factors I, 7, 9, and 10. You've got to memorize that sequence. That sequential MOA is literally the foundation for understanding both vitamin K therapy and its antagonist. Section 3, Iron Therapy Clinical Review. Time to build some blood. Okay, let's methodically run through these iron absorption interactions because they are board exam gold. We know iron is essential for hemoglobin, myoglobin, and cytochrome synthesis, right? And it's absorbed mostly in the duodenum. But here is the kicker. It must be reduced to the ferrous form, that's Fe2+, before your body can actually absorb it. Now pay close attention to what messes with this process. Gastric acid and ascorbic acid, or vitamin C, strongly increase absorption. On the flip side, alkalis, phosphates, phytates, and tetracyclines decrease it. Once it finally gets absorbed, it's either stored locally as ferritin in mucosal cells, or it hops a ride through your blood bound to transferrin. When we actually go to treat someone, route selection is everything. Oral iron preparations, that is always your preferred first-line approach. We're talking straightforward options like ferrous sulfate, ferrous gluconate, ferrous fumarate, colloidal ferric hydroxide, and carbonyl iron. Then, on the other hand, we have parenteral iron preparations. These are the heavy hitters, indicated only when oral therapy just flat out fails or isn't viable. These are your organically complex formulations, things like iron dextran, ferrous sucrose, ferric carboxymaltose, iron isomaltoside 1000, and iron sorbitol citrate. So you might be wondering, when exactly do we pull the trigger on those injectable options? Well, the specific indications for parenteral iron are super clear-cut. You only inject iron when the patient simply cannot tolerate oral iron, when their gut fails to absorb it, when they're non-compliant with taking their pills, if they have a severe deficiency paired with chronic bleeding,
or if you're giving it alongside erythropoietin for a patient with chronic kidney disease.
Now, the absolute crucial point for dosing is this magic number, 4.4. This is your vital coefficient for calculating the total iron requirement for your patient in milligrams. The formula you want burned into your brain is this: 4.4 multiplied by the patient's body weight in kilograms, multiplied by their hemoglobin deficit in grams per deciliter. It's a beautifully elegant formula because it accounts for these exact amount of iron needed to fully replenish the body's depleted stores. But listen, you have to respect the clinical boundaries here. Major contraindication: iron sorbitol citrate must not be given intravenously. Never. The reason? It causes this incredibly rapid saturation of transferrin receptors, which dumps way too much free iron into the blood, leading directly to severe iron toxicity. And speaking of side effects, you always need to be on high alert for acute iron poisoning. This mostly happens in infants and children who maybe get into a bottle of pills. It's pretty rare in adults. Treating this is an emergency. It requires immediately stopping any further absorption from the gut and aggressively binding and removing the iron that's already made it into the system. Section 4, Vitamin K Clinical Review. Let's transition from building blood to clotting it. Look closely at how the body actually utilizes vitamin K. We know it's a fat-soluble dietary principle that we absolutely need to synthesize clotting factors. But the utilization pathways are split. The fat-soluble forms of vitamin K are absorbed from the intestine via the lymph, and they desperately need bile salts to make that happen. Meanwhile, the water-soluble forms bypass all that and absorb directly into the portal blood. Keep those distinct pathways straight in your head, because they dictate exactly how and when specific deficiencies are going to show up in your patients. Ultimately, there is really only one core reason we administer vitamin K: the prophylaxis and treatment of bleeding caused by a deficiency in those clotting factors. There are 6 classic clinical scenarios you'll be tested on. Number 1, simple dietary deficiency. 2, prolonged antimicrobial therapy. 3, obstructive jaundice or malabsorption syndromes. 4, liver disease. 5, newborns, they get a prophylactic shot. And 6, an overdose of oral anticoagulants. These are all prime exam questions, but especially watch out for that tricky link between prolonged antimicrobial therapy wiping out the normal gut flora and causing a deficiency. Okay, we really need to untangle this highly complex side effect context. When you start a patient on initial warfarin therapy, remember, that's a vitamin K inhibitor, it actually causes a paradoxical increased risk of clotting at first. This crazy early window phenomenon is known as hypercoagulation, or dermal vascular necrosis, famously tested on boards as purple toe syndrome. This is primarily seen in patients who have an underlying genetic deficiency of protein C. You see, protein C is an anti-clotting factor that also relies on vitamin K, but it depletes way faster than the pro-clotting factors, creating that temporary, dangerous clotting risk. Section 5, Quick Exam Revision Summary. Let's lock in some points. All right, rapid-fire toxicology time. These are super high-frequency test items. The antidote for acute iron poisoning: deferrioxamine, given by IM injection. What about treating chronic iron overload, like you'd see in thalassemia? That requires an oral chelating agent like deferprone. If a patient overdoses on oral anticoagulants or warfarin, your antidote is vitamin K. And lastly, the antidote for an overdose of thrombolytics involves epsilon aminocapric acid, or EACA, and tranexamic acid. Memorize these. And this brilliantly illustrates how interconnected these hematological systems are. Because beyond just iron, vitamin B12 and folic acid are essential maturation factors, absolutely required for DNA synthesis in your red blood cells. Folic acid is needed for reduction to FH4, where it acts as a methyl donor, and vitamin B12, that's the essential cofactor to convert methyl FH4 to FH4. If a patient is deficient in either of these, the DNA synthesis breaks down, resulting in megaloblastic anemia, characterized by those giant immature red cell precursors. Oh, and never forget, folic acid is routinely supplemented in pregnancy to prevent neural tube defects. Let's do a quick, direct comparison to really consolidate everything we've covered today. Iron therapy heavily relies on an acidic environment aided by vitamin C, or HCl, to ensure the successful absorption of the Fe2+ form in the duodenum. Compare that to vitamin K, where the fat-soluble forms desperately need bile salts to be absorbed via the lymph, while the water-soluble forms bypass that and go directly into the portal blood. These are 2 completely different physiological absorption demands, and they dictate exactly how we manage our patients' treatments. Please always remember the core takeaway from this explainer. clinical pharmacology requires incredibly strict attention to detail. Your solid grasp of MOAs, contraindications, and side effects are quite literally the pillars of patient safety. You are memorizing all this complex data not just to pass your medical boards, but to protect the actual human beings who are going to be trusting you with their care.
So, I'm going to leave you with a quick clinical scenario to challenge your thinking before we go. If a patient presents with a severe bleed and a history of long-term antimicrobial use, how quickly can you trace the physiological cascade from that initial gut flora depletion all the way to a vitamin K deficiency and finally down to factor VII inactivation? Just take a second and walk through that pathway in your head. Master these mechanisms, and you are going to be more than ready for both the boards and the wards. Thanks so much for joining me on this explainer, and keep up the fantastic studying.